Good morning. Welcome to this unknown session from CTA Pathology. I'm Curtis Thompson. Today I'm going to look at the unknowns from Lieber chapters 27, pigmentary disorders, 28, benign pigmented neoplasm melanoma, nevi, and tumors and cysts of the epidermis. So to get started, I have the unknown clinicals here on the first slide, and then the answers on the next slide. So if you want to challenge yourself, go to the beyond the answers and work on that and then check them yourselves. So starting with case one, is a 52-year-old male, a rash, dermatosis, NOS, psoriasis, tinea corporis, lichen simplex chronicus. So here you can see the biopsy, some sun damage, a little bit of fibrosis here. And then a little bit of like what looks like interface here with some lymphocytes and maybe, vascularization of the basalis here a little bit more. And then are you like wondering if those are lymphocytes or melanocytes? Not quite sure. But PAS is negative. It's not tinea. It's not psoriasis. It's not rubbed. See the nice stratum corneum basket weave. This artifactual basket weave is a normal finding. So we do have a little bit of an inflammatory process. So what does this end up being? Well, when we look at a Fontana-Masson here, we can see very little pigment in the epidermis. One thing you have to play around or always think of when you're doing Fontanas and looking for pigment. Here's a melanophage, a tiny bit of melanin in the dermis, but you have to look at the patient's, consider the patient's skin type, and the lighter the skin, the less pigment you're going to see around. And then when we go to a melan A here, we see that there aren't any lymphocytes left, and we have a nice control here showing junctional melanocytes. And then nothing left here. So this is just a little bit of an inflammatory stage of vitiligo. And you still see that, you can see that these cells that we saw on the H&E here are not melanocytes. So if we go back, what do you need to know about vitiligo? No, there's an inflammatory stage and an end stage. During the inflammatory stage, you may still have a few melanocytes. And as I said, you may have different amounts of melanin still present depending on the patient's skin type. There's an old concept called trichrome where it was not pigmented, partially pigmented, and entirely depigmented, and kind of people thought you needed to sample all parts. That's not necessarily true. My recommendation is sample the end stage. And it is difficult to diagnose on H&E alone. You can see that on this case. We couldn't really be sure what was going on there with that little bit of interface looking process. And immunos, SOX10 or melan A are useful. I'm not a big fan of melan A, but this is one time it could be used. So on to case two. This is a 63-year-old with a non-raised, non-tender purple lesion, 2 by 1 centimeter in the oral palate. And you can see here, this is normal salivary gland. We don't get to see that very much. We usually see mucocils where it's been altered, but this is what normal looks like in the mouth. You can see a little bit of hyperkeratosis, but I think that's normal for sight. And then where is this pigment? Where is the vascular? We don't see any kind of vascular proliferation. And then you can start seeing pigment here. And it's kind of globby, a little bit larger than you'd like to see with melanin. Melanin is finer. It can be really hard to tell iron from melanin, and special stains are useful for that. Depends on the patient's makeup of their melanin. If they have, depending on their components of eumelanin and pheomelanin, the red, the brown, and the more red may be really hard to tell from iron. So anyway, we definitely have pigment here. So what is this pigment? So getting more history on this patient, we find that the patient's been on minocycline long-term. So this is drug-induced minocycline pigmentation. You can get it from other drugs, chlorpromazine. And the big concept here is that pigment that we're looking at, as I was just discussing, can be melanin or stained for melanin, and it can be iron. And there was a concept, old concept, that we had 3 types of minocycline pigmentation: all melanin, all iron and then a mixture. We've kind of moved away from that, but you just need to know that you might only see one or the other in this entity. Differential post-inflammatory pigmentary alteration is probably the biggest one. So going on to case number 3, I'm gonna have to reboot this to bring it up. This is a 53-year-old male, 1 centimeter, pinkish brown patch on the abdomen for years. So let me bring this up one more time. So that one will do. So here you can see dome shape. Look, it's been rubbed. This is on his abdomen, and this looks like the bottom of the foot. So that is definitely been externally irritated. And then you can see the spindle cell proliferation here, nice spindle cells, and then pigmented macrophages in between them. And the dermis is fibrotic. So this is a fibrotic dermis. This is not normal. And it actually looks somewhat similar to the collagen, thickened collagen bundles you see in non-melanocytic lesion, dermatofibroma. So is this a pigmented dermatofibroma, or is this a melanocytic lesion? Well, usually the difference between those, you will see the epidermal change in a dermatofibroma. Hard to tell here because it's rubbed. But then when you go and do some melanocytic markers, you can appreciate that it is melanocytic. So what is this? A couple more things I want to show you. This is a blue nevus, and I'm not going to show you a melanocytic marker. I'm just going to tell you it's a blue nevus. But we do use now PRAME a lot. This antibody is one of the first that's been useful for telling whether something's benign or malignant. Of course, like most antibodies, it's not 100%. But these are the pigment. This is not the staining of the immuno. And here's a positive for what an immuno would look like. So that is generally positive in melanoma and not. And P16 similarly was done here and also is negative right here. So once again, you can see the pigmented macrophages right there, but you can't see any staining. So what is this? This is a common blue nevus, and just a big concept in blue nevi. This is what Dr. Bernard Ackerman used to teach. It's composed of melanocytes, melanophages, and fibrosis. And this is a good example of the fibrosis that's dermatofibroma-like, melanophages scattered between, and the melanocytes. And so these melanocytes in blue nevi can vary. Here they're more spindled, a tiny bit epithelioid, but you can have those really delicate dendritic ones in like the nevus of Fido and Oda. But if you just think blue nevi in general have these components, and you're going to see varying amounts of all 3 of these depending on the typical blue nevus. So this common is the one that's hard to tell from a pigmented dermatofibroma. And just a word to the wise, remember there is blue nevus like melanoma. You can have metastasis that look just like a blue nevus. There's a patient in our practice we receive biopsies on repeatedly where there'll be 4 or 5 blue nevi looking lesions, and then you realize it's this patient who is continuing to get small metastases. And then be careful with blue nevi on the head and neck, especially of older patients, especially ones that are partially sampled. So even if you're convinced it's entirely benign on the head and neck of an older patient, but it's transected, the patient should be followed for recurrence and biopsied more. It's not really clear whether these patients they are malignant transformation or whether they were melanoma all the time, but just a little bit of a caution on these. So let's go on to case number 4. This is a 40-year-old female, 3 millimeter C-shaped pigmented macule on the left tricep. This slide's going to be better. You can see here a shade biopsy, tiny bit dome shape, not much going on. Here's another section. Maybe in the middle of the reed, you're a little bit elongated, and you can start seeing the pigment in the epithelium here, and also melanophages here. And so we have a pigmented lesion. We found it C-shaped. not very standing out as very many melanocytes. So one of my concepts is that you can't find the melanocyte that's not melanoma. So that's a good, just as if if you don't have lymphocytes, it's not lymphoma. But you do start to see these melanocytes here, a little bit plump, but not terribly large. And you can appreciate that they're not confluent. So in melanoma in situ, we like to see confluence. So they run over here, they run here, they run here. So basically it's a anaplasia back to a embryonic behavior when the neural crest melanocytes are populating the epithelium. So that's what melanoma in situ is. So here, when they're just on the reedy, it's less worrisome, and that's one thing we're looking for in the kind of benign versus malignant. And here is a SOX on the same case. I really like SOX much better than Melan-A, and it's been shown in studies to help you downgrade melanocytic lesions, whereas Melan-A often leads people to upgrade, which I've been guilty of when it first came out. But you can see here the melanocytes are mostly on these reedy. So if you do a reediectomy, cut them off here, they're pretty much all gone. Now, what is this? There's no nest, so it's just single melanocytes. So this is a simple lentigo. So I want to talk just a minute about lentigo. Simple M, mean it's a melanocytic, so it's baby nevus, and we see it in younger people, versus solar lentigo, which is grows up into reticulated sub-K. So these are, one's melanocytic and one is keratinocytic. They're both pigmented. They both do show increased melanocytes, but the solar lentigo often isn't apparent that they're increased until you do a SOX or an immuno. So no nest, still single. We call it simple lentigo rather than a junctional nevus. Be careful in older patients. And the World Health comment on this is careful if they're greater than 4 millimeters or on sun-damaged skin. So next case, number 5. Let me see if I can model. Yeah, we should pull all these up at once. We can rescan them and put them in an unknown set, but I didn't do that for this. So here we have a 43-year-old female, pigmented periurethral, so a genital pigmented lesion, 43 years old. You can see the punch. Typical in these punches from the genital region, they're often squeezed because they're difficult to obtain. Squeezing can happen anywhere from when the person who does the biopsy, the person who puts it in the bottle, to the person who takes it out of the bottle, or even cutting the sections in the lab. But you need to look for it by being squared off. That's what the forceps do. And it's not important in this case, but it's important because it often makes things look more atypical in the area where it's squeezed. Anyway, back to the pigmented lesion, periurethral. You can start to see the pigment here, and there's pigment in the epidermis, and then there's pigment down here in macrophages again. And in the epidermis, you can see here's a melanocyte, and these dendrites move out between the keratinocytes. And this is typical of a near mucosal lesion, typical also in the nail epithelium, these dendritic melanocytes. So they're normal resident. And when they produce a pigmented lesion, what is this? It's a genital melanotic macule. So number 5, genital melanotic macule, dendritic melanocytes. So just normal melanocytes in this location are dendritic, but also in this benign lesion, they're also dendritic. And in the past, people tried to ascribe the tibia to the length of those dendrites, and this never held up. Also know that the melanotic macule of the nail, which we're currently calling benign activation of nail unit melanocytes, looks very similar. So no significant atypia. If you're worried about atypia, then simply just follow it, sample it more, and because you could have an MIS in this area that does have dendritic melanocytes also. So the best thing to do is follow them if you're worried. So number 6, let me get this one. It is CT1911427. It's a 67-year-old female with light tan pigmented patch on the lower chest. Dysplastic nevus versus melanoma, 67-year-old. So light tan. Here we see lots of ink from the biopsy was inked, and we see a lot of squeeze artifact again. But as you go on a little higher power, you start to see this proliferation of cells right here in the papillary dermis, start to see a little bit of pigment, and they're clear. So we have these clear cells. A lot of them have cytoplasmic vacuoles, almost like a sebocyte, but you also have pigment associated with it. And as you go around here, some of them are a little more foamy, xanthomatous. So there's a differential for clear cells that we need to talk about a little bit. And one thing that is nice in this case is you hear some more of the clear cells, some of the vacuoles, but then you start to see some more ordinary, small, round melanocytes over here. And this is really typical. So what is this? This is a balloon cell nevus. And fortunately, we usually just get balloon cell chains, like part of the nevus has these balloon cells. So it's generally not all of them, but you get clear granular cytoplasm. I don't know if this is on boards or not, but electron microscopy will show degenerated melanosomes. We still go with nuclear atypia, cytologic atypia. So the clear alone doesn't make it atypical. You have to go with size of nucleus and how they're arranged. So architecture, are they single at the junction and all that, and then how much atypia. So in the differential, so it's a clear cell differential, and I wanted to just quickly show you this. This is from the DermNet New Zealand site, and this is a rare tumor you might not have heard of called PEComa. It stands for perivascular epithelioid cells, PEComa. We see them in other organs, and the reason I'm mentioning it is this is one of the entities that can be confused with a balloon cell nevus. These are glycogen, so they'll be PAS positive, which is helpful in that. So things that make a cell clear, glycogen or lipid, like in a sebocyte. So in this one, it's glycogen. In the balloon cell, it's degenerated melanosomes. But the thing you need to know is this PEComa stains a little bit like a melanocytic lesion, HMB45, MITF, but it's S100 negative. So the differential, same with is granular cell tumors, which is the one in the oral cavity usually we talk about, melanocytic lesions. There's a rare tumor called clear cell sarcoma of soft tissue. It's very difficult to stains just like melanoma. So you have to be on the lookout for it and know that it exists, however rare. And then metastasis, renal cell is often clear. So on to the next case. This one too. So on number 7, 7 is CT20-11510. See if I can tee up the next one, CT19-20373. See if that works. Okay, so here we have, that one is a little bit blurry there. Here we have another melanocytic lesion, and this is once again 61-year-old irregular brown patch on the shoulder. So we're on sun-damaged skin here. And you can see here a proliferation of highly atypical cells, even at this power. Lots of melanophages, so it's pigmented. And then you can see this foamy cytoplasm, similar to what we were looking at in the other. And this is just a good demonstration of having those same clear cells. Here, look at the junction. See our clear cells right here, lined up singly, upward scatter. Look, that one's trying to leave the planet here. So here we have a good example of a balloon cell melanoma. So it's so this is just to point out once again, the balloon cell doesn't make it malignant, but the cytology, the arrangement, the singles, the clinical all make it melanoma. So then on to the next case that is working. This is number 9, and this is a 34-year-old male. No. This is I'm sorry, this is 8. This is 8. 35-year-old female, 1.2 centimeter, half pink, half tan patch changing, rule out melanoma, half pink, half tan. So you can see a nice shave. There's a shave excisional biopsy. If you know how to do this, it's really nice for melanocytic lesions because it's so important to see the edges of these lesions. And if you could do a scoop shave, give 2 tips, and get it out on the first time, you've saved everybody a lot of heartache, cost, pain. And but here you can see the proliferation, fairly symmetrical. And on higher power, you start to see that a lot of these are lymphocytes. Small, round, dark ones are the lymphocytes. Then you can see pigment and melanophages once again. So it looks like a melanocytic lesion with a lot of lymphocytes intimately associated with it. And then if you go, we have a melanate here, and you can see on this, oh, indeed, there are melanocytes, both at the junction, look singly across there, and then also in the dermis. So what is this? You worry about this confluent single, but it's also reactive. It's also rubbed. There's some perikeratosis, so we can allow for more confluence, and it does stop. Stops here, stops here. So this is a halo nevus, a really good example of a halo nevus with residual melanocytes there and reactive, and they're also in the dermis right here. So halo nevi, younger patients. Be careful with older patients. If you encounter a lesion like this in an older patient, the lesion itself may not be melanoma, but they may have a melanoma somewhere else that's activating their immune system. And then just know probably at least half or more of the time when we see a histologic halo, such as in this case, you may not see it as a clinical halo. So that's very common. But benign reactive, you often see the silhouette of the nevus, and that's what was quite apparent in this one. You can see that you can see where the nevus was, kind of highlighted by the lymphocytes, and you may not find the melanocytes even with an IHC. So if it's advanced enough, they may all be gone. So next case, let me tee these up again. This is number 9 coming up. Here we go. Number 9 is CTA-25909. And then I'm going to tee up the other one if I can, which is going to be 10. It's done, so we can go and enjoy the sun today. It's sunny in Oregon today. Okay, here's the first one. So number 9, 34-year-old male with re-excision of a pigmented lesion at the site of a biopsy of what was called a benign congenital nevus. So here you can see right here, this is the center of the ellipse. I recommend if you get an ellipse, this is 3 slides, you find the biopsy site or the scar in the center and then work out from there. You don't want to just start at one tip and go. You want to go to where the business is and then move out to the tips, and that helps a lot. So you can see here the scar from the prior biopsy, even some keloidal collagen in the scar. And then you start to see something here, pigmented, lots of macrophages right here. And at the junction, oh my goodness, confluent, single, enlarged, melanocytes, even maybe a little bit upward scatter, looks a little rubbed, and then inflamed lymphocytes in there, and some macrophages. So the point is, this could go in a book as an example of melanoma in situ, but it isn't melanoma in situ. No, this is a young person, partially sampled nevus, and it's a recurrent nevus. So it wasn't even called atypical. So this is a recurrent nevus, and these are really, really, really a challenge in dermatopathology. Very common in partially biopsied nevi of young patients. In any patient less than 25 years old, if it's partially sampled, I put in a comment that the nevus looks benign, but it may persist or recur given the young age of the patient. It can also occur in traumatized nevi. So you have a dome-shaped nevus, even the flat Clark's-like nevi of the trunk have a little bit of a rise to them, and they get traumatized. So the center of these nevi often get scraped, a little bit of scar, and single cells over it. And this is well known. We can accept more single cells, atypia, in the center of nevi, and this doesn't make it melanoma in situ. But it's a challenge. Histopathology, the single cells, and here's the big point, they're only over the scar. So if they exist beyond the scar, we have to consider melanoma in situ there. And they usually have a banal cytology, but the younger the patient, the more atypical they can be. And you can see that in this case too. But here's the point. So here's the scar, and just see how they stop. They do not go off over here. So single cells continuing to go off, we would entertain a diagnosis of melanoma in situ. So the one big point here is that when one of these occurs, you know, the young patients, you need to leave them with a big scar. But at this point, it's important to see the edges. So you can't just do another, if you do another shave right through here, we won't see the edges where to make sure it doesn't go out over where there's no scar, and we'll end up having to hedge, and we'll end up having to go back. So you might as well just excise it one way or another to be able to see the edges at the point that it's recurrent. All right, so next case is number 10. 8-year-old male with a polypoid lesion on the lateral neck. Immediately looks like a sub-K, right? A papillated sub-K, the nice squared off digitations, crenations like in a castle. That's what you like to see for sub-Ks, but the patient's only 8, right? So it's not a sub-K, it's an epidermal nevus, and a little bit of fibrosis here and lymphocytes. And that's one of the features of it, is fibrosis underneath this hamartomatous proliferation that you see less in sub-Ks. That's just probably the only way other than the age. So epidermal nevus looks like a sub-K, but in a young patient. And then just a comment, I'm not going to show you a nevus sebaceous called an organoid nevus, but know that over an organoid nevus, a nevus sebaceous, you often have perfect epidermal nevus-like change. So the concept here is a epidermal nevus involves only the interfollicular epidermis. It's on the surface of the skin, and an organoid nevus or a nevus sebaceous is a hamartoma that involves the adnexal structure. So follicular, eccrine, apocrine, duct-like. So you can see all these other components in the nevus sebaceous, in the organoid nevus. And the reason we went to calling it organoid nevus is because you see more hamartomatous change of the adnexal than just sebaceous. So nevus sebaceous is too limiting for it. But I recommend having a lot of give in these. It's if you can't, if there's something isn't clear, just back off and just call it a hamartoma, a nevus, and leave it there, and don't try to pocket it too carefully. That's all I'll say about that. That's a big subject. There's a whole lot more with epidermal nevi, organoid nevi, and syndromes, but that's all we'll touch on today. 12947. And I'm going to get the next one teed up too, if I can. This one is going to be number 12, which will be the next. We're almost to the last ones. Tee this one up, number 12, CT20. Here we go on this one. Here you see a nice, so this is number 11, 73-year-old male, pre-tibial patch, rule-out dermatofibroma. Well, you can see why it's considered a dermatofibroma. It's dome-shaped, sticking out, pre-tibial. But then you can see something's amiss here. Here we have normal epidermis, then going into the very center, very, very acanthotic, psoriasiform-like change, and then going back to the thin. So here's our lesion, maybe some fibrosis under it for sure, but look at this, see these pale cells. So we're stepping off nicely from the normal purple staining epithelium into this pale, clear component. And then you can actually see, look, there's thinning of the suprapapillary tips, dilated papillodermal venules, some parakeratosis, and then even some neutrophils. I'm not going to spend a lot of time finding them, but they are here in it. So it looks like psoriasis. Like if you got just this and didn't see anything more, you'd think this is psoriasis. So that's a good way to figure out what this lesion is. But the fact that it steps off, see how it goes just from totally normal into this step off, makes it our clear or pale cell acanthoma. So things to know, it can be anywhere on the body, but often near the knee, which it is in this case. Histopathology, the clear cells, everything I just said, think about psoriasis. Neutrophils may or may not be there, but I think they usually are, the well demarcation. And then know that the clear, we talked about what makes cells clear. Here it's glycogen. So remember in the clear cell nevus, it's degenerated melanosomes. In sebocytes, it's lipid, which washes out during processing, so you can't stain for it anymore. The glycogen remains, so you can do a PAS on these and light them up, which I don't have today. And then last case, 72-year-old man with pustules, erythema, and edema of the scrotum. And you can see this punch biopsy here shows something going on. Marked acanthosis of the epidermis in a psoriasiform pattern. And then you can very quickly start to appreciate that there's very atypical cells here. So these are not normal. You don't see that normal basal or epithelium going up through stratum corneum and maturing. So this is an intraepidermal malignancy. Here you can see pagetoid-like cells. Like when you say pagetoid, you mean looks like they're crawling through the epithelium, large. And then what else do we see in this? We have a cytokeratin 7. This is the most important immuno to see. You can see they light up very strongly with cytokeratin 7. And that leads us to this diagnosis of extramammary Paget's disease. This is usually genital in older men. What's the cell of origin? We don't know. Could be prostate, could be other glands. They will mark with different, prostate markers, but we don't know about prostate markers in other adnexal structures in the genital region. And it's often not considered in the differential, and you could see that in this case. It was pustules, erythema, edema, was not even sent in as rule out extramammary Paget's. You have these atypical intraepidermal cells. Be careful not to call it melanoma in situ. In this particular example, that is not a problem at all, but I have made this mistake historically. So word of caution here, but make sure you don't, and you mark it. I recommend doing a cytokeratin 7 only. There's other cytokeratins you can do, but then you start to get variability. And cytokeratin 7 is pretty reliably, very strongly positive. And I just wanted to mention the P63, which I think we have one here. Yeah, we do. Wanted to mention P63 because it's been an important antibody for us. And you can see here it also is lighting up the tumor cells, but it's also lighting up probably normal cells in here. But the idea of P63 is it stains pretty much everything that's in the skin, that's epithelial. So, and the one utility it has, and the reason I'm pointing it out, is adenocarcinoma that's metastatic to the skin is negative by and large. And so adenocarcinoma, whether it's an adnexal carcinoma or this, that's primary to the skin will be positive. So it's actually useful, but it's only useful for adenocarcinoma. It's not useful for squamous because it will hit squamous cell carcinoma. So that is it. Thank you very much. Hope these were somewhat educational. I know the melanocytic is a huge subject, and there's not enough bandwidth to talk about all the subtleties of melanocytic, but hopefully you're picking that up over time in different ways. And I also skipped over most of the basal cell, squamous cell components because you also get a large amount of experience with that just in your daily work. So any questions, you can email me at my Gmail and text me, WhatsApp, and come to our website and check it out. Thank you very much.